Next presentation is by Virginia Utz, PhD, resident in the Department of Ophthalmology and Visual Sciences. She will speak on spectral domain-OCT imaging of melanocytic lesions.
Good morning. I'm going to be speaking about some of our preliminary research, and I'll try to move it along so we can get back on track here time-wise. I'd first like to thank my co-authors, though, Sean Wilker, Stephanie Burke, and Johnny Tang for their help with this project. The collaborative ocular melanoma study was the first multi-centered randomized control trial to assess treatment modalities for ocular melanoma. And basically there are three different groups. There were the small-sized melanoma, which was an observational study, medium-sized melanoma with the size criteria as above, and the large-sized tumors. I'm going to focus on the small-sized melanoma observational study in this background because that's what the upcoming research will be involving. And in this observational study, basically patients were followed by stereo images for tumor growth, and that was defined as an increase from a small to a medium-sized tumor. In this study, they also were able to determine the features that were predictive of tumor growth, and in the analysis, they looked at the time to treatment as a surrogate for tumor growth, and 38% needed treatment at 7 years. So even these smaller tumors are of clinical significance. However, the tumor-related mortality was 1% at 5 years and 7% at 8 years, so a lot lower mortality than in the medium or large-sized tumors. So a diagnostic dilemma for us is when we're doing a clinical exam, are we seeing a small melanoma or a large choroidal nevus? Early detection of choroidal melanoma at an early stage may lead to a better prognosis in both local treatment and prevention of systemic metastases. And so that's one of the major reasons for our study. And then there's also a relationship between growth and malignant potential. However, it remains controversial as large nevi actually will grow over time as well. And so these lesions are better referred to as indeterminate choroidal melanocytic lesions because there's a lot of ambiguity. Clinical features that are associated with risk of growth are tumor diameter and depth, of course, presence of orange pigment, presence of subretinal fluid, absence of drusen. Drusen is a sign of chronicity and not something that's usually actively growing. Absence of retinal pigment epithelial changes, also another sign of chronicity adjacent to the tumor. Acoustic hollowness by B-scan, findings on fluorescein angiography, the presence of symptoms, and location close to the optic disc. The role of Fourier domain optical coherence tomography in the evaluation of IML is very important. Subretinal deposit, subretinal fluid, RPE irregularity can be determined, and it's also a non-invasive way to detect and a very sensitive way to detect these features. And in fact, the clinical exam, which is usually considered the gold standard, even with contact lens biomicroscopy, for small amounts of fluid, as they've shown in macular edema, physicians are unable to detect the subtle amounts of fluid, whereas OCT can. In terms of OCT and the evaluation of subretinal fluid and melanocytic lesions, in a time domain study, they found that OCT can detect these secondary retinal changes in cases of choroidal nevi and melanoma. Spectral domain, however, is superior to time domain, and it's less prone to motion artifact and much more sensitive in terms of microns. So the purpose of our study was to compare the detection rates of subretinal fluid and subretinal deposition, drusen, orange pigment, by spectral domain optical coherence tomography as compared to the clinical exam by a trained observer in cases of indeterminate melanocytic lesions referred to the VA Medical Center. This was our preliminary data is a retrospective case series of 10 Caucasian males with intermediate melanocytic lesions, and basically we obtained we looked at the stereofundus images of these lesions, and they were looked at by a masked retina subspecialist for the presence of drusen, subretinal fluid, and orange pigment. And then the OCT was also reviewed by trained observers who were also masked for the presence of subretinal fluid, focal thickening of Bruch's membrane, as well as subretinal deposits. We used a Fisher's exact test to compare the detection rates by the clinical examination as compared to OCT. And our findings are as followed. Subretinal deposits by photographic examination, clinical examination, were 75% as compared to the OCT. Subretinal fluid, 66% as compared to the OCT. However, given our population size, neither of the clinical exam versus OCT was not significant. In fact, we would need a sample size of 40 to have enough power to detect a significant difference. Of note, by chart review, subretinal fluid was only detected by the referring physician in 16% of cases, and so trained retina specialist versus the referring doctor, there's probably some significance there. So just an example, this is a subretinal fluid that was detected by both the clinical examination as well as the OCT. The subretinal fluid is located here. Here is our nevus. Spectral Domain-OCT, you can get these beautiful three-dimensional images that really give you the contour of the lesions. Here's another example in which clinical exam did not detect the subretinal fluid, and you can see the image is limited by a cataract in this patient and very difficult to detect subretinal fluid even with the stereo goggles. However, there is some subretinal fluid inferior to the lesion, and then here we're just showing these deposits, and you can't really distinguish whether it's orange pigment or drusen in these cases, and so really we need autofluorescence to correlate the clinical picture with the OCT. And then the other thing that we found was in some of the cases there was cystoid intraretinal spaces that mimicked elevation from subretinal fluid, and clinical significance of this was not something that was discussed in these original studies that were pre-OCT by the COM. All right, so in conclusion, the OCT provides value to the clinical exam for detection of subtle amounts of subretinal fluid and RPE changes. Basically, the OCT combined with the clinical exam led to the reclassification of 6 patients and prompt referral to a subspecialist, although even if we're detecting these lesions very early, we can't rule out that there could possibly be a lead time bias in diagnosis, which wouldn't necessarily correlate with prognosis for these patients. Significance of CME was not addressed in the COMS, as I mentioned, as OCT was not available at this time. However, in one study using time domain, they showed that intraretinal cystoid degeneration was more common in a melanoma as opposed to a nevus, so this may represent an important feature that can be detected by OCT. And once validated in a larger number of patients, it can be incorporated into diagnostic algorithms. In terms of our future studies, we actually got our IRB revised to recruit patients in a prospective manner so that we can actually determine whether clinical exam versus OCT is the same or statistically different in terms of sensitivity. We're also going to be looking at autofluorescence as well to distinguish between drusen and orange pigment. And man versus machine, who will win? So we'll see with this future study. Those are my references. Thank you for your attention.